This is First Pediatrics. Hi there, my name's Chris.
And my name is Katya.
And welcome back to First Pediatrics. Katya, could you tell us a little bit about yourself?
Yeah, for sure. So I'm a fourth-year MedPeds resident, and I'll be going into combined hospital medicine with an interest in breastfeeding and lactation medicine. I'm also a mom, and that's what initially sparked my interest in this topic and inspired me to pursue additional training.
Thanks, Katya. And could you remind our listeners a little bit about our podcast?
Sure. So First Pediatrics is a peer-to-peer podcast geared towards pediatric resident education. Our goal is to address your first management experiences by bringing you evidence-based content to help you on the wards and make daily life more manageable as a resident.
So I understand our topic today is all about breastfeeding, which is an area of significant interest and research for you. Do you mind sharing a little bit about why you chose to talk more about this topic and teach on it today?
Thank you for asking. So, breastfeeding is such an important topic in pediatrics, and many residents find it challenging to answer questions and provide evidence-based support to families because, honestly, we receive pretty limited training on breastfeeding management. So, whenever I get the chance, I'm excited to share my knowledge and passion for breastfeeding. This topic is broad and nuanced, so for the purposes of this episode, we'll focus on management in healthy term newborns.
Okay, that makes sense. Do you want to go ahead and get started with the case?
Yeah, that sounds great. Okay, Chris. Let's say you are an intern on the newborn service and you get a call that a patient is having difficulty latching to the breast and has not fed in 6 hours. The nurse asks you what you would like to do next.
Okay, so I usually start by asking some history questions. And in this case, we have both the baby and the birthing parent. I usually would ask about both of their histories. Can you share a little bit about the baby, their gestational age, and any other notable history to get started?
For sure. So this is a 23-hour-old baby boy named Alex. He was born at 39 weeks and 4 days via cesarean delivery due to breech presentation. His mother, Katie, is a 27-year-old P1, now G1, and medical history is notable for obesity. The pregnancy has otherwise been uncomplicated. You come to the patient's room and Katie shares that the infant latched on once, and since that time, it has been difficult to get him to feed.
So based on what you're saying, it doesn't sound like there's any notable prenatal concerns or past medical history for the mother affecting the baby. I also like to make sure that my patient, and in this case, the baby, is not sick before starting to troubleshoot any of the feeding problems. And I usually try to get a general sense from the vitals. So do you mind sharing also, other than the vitals, maybe birth weight, and help me determine if this patient is at risk for hypoglycemia as well?
Those are all really good thoughts. So you're right. The baby is full term. He's 3 kilos, which is considered appropriate for gestational age, and doesn't have any maternal risk factors for developing hypoglycemia. So testing would not necessarily be indicated at this time solely based on history. Babies are used to having a constant flow of nutrition from the placenta, so this new environment and periodic feeding boluses are foreign and new. Babies do not need to eat a ton in the first 24 hours, and honestly, feeding patterns in the first 24 hours of life are very variable. But at minimum, you want to make sure that they don't have symptoms of hypoglycemia, such as lethargy, hypotonia, tremors, and fortunately, this baby is intermittently wakeful, he's rooting, he's sucking his hands, and he appears well. In terms of vitals, they're also age appropriate. He has a heart rate of 145, respiratory rate of 40, and SpO2 of 99% in room air.
Okay, got it. So this all sounds like good news. Usually in a situation like this, I would have most likely met with the family on day one, or I've gotten some handoff on the family's goals for feeding. Do you mind sharing what we know so far about the family's goals?
Yeah, this is so important to make sure we do not assume what the family's feeding goals are. The family has shared that they would like to exclusively breastfeed, but are open to feeding formula if medically indicated. This is their first child, so they're not quite sure what to expect, but they just want to do what's best for the baby.
All right, great. So it sounds like now would be a safe time to troubleshoot this feeding concern. But before we jump into thinking about management, I do want to take a moment to step back and think about the different types of feeding and why we often recommend breastfeeding. Do you mind sharing some of the benefits of breastfeeding?
So, most importantly, breastfeeding is important to our patients, so it should be important to us as their doctors. In the United States, more than 85% of pregnant patients intend to breastfeed their infants, and additionally, the health benefits to both the mother and the infant are truly incredible.
So do you mind maybe breaking that down for us? Let's say the family is unsure if they want to breastfeed. What are some of the benefits you might mention?
Yeah, so the list is quite long, but for the infant, benefits extend beyond infancy. And in many studies, breastfeeding is associated with lower rates of infections, sudden infant death syndrome, atopic dermatitis, inflammatory bowel disease, childhood leukemia, diabetes, asthma, lower rates of obesity, and even a reduced risk of all cause mortality in adulthood. There's also data to suggest that infants that are breastfed have better neurodevelopmental outcomes. In terms of breastfeeding mothers, they have a low risk of diabetes, hypertension, and breast, endometrial, and ovarian cancers. There are also some incredible benefits that we still do not fully understand, including the establishment of the microbiome, dynamic immunomodulation, and epigenetic effects. And those are areas that are all currently being researched.
Wow. Yeah, that's a pretty long list. And it sounds like the benefits are not just for the baby, but are also for the breastfeeding parent, which you already mentioned. Are there any recommendations from major health organizations that we should be aware of?
Yeah, so the American Academy of Pediatrics and the World Health Organization both recommend exclusive breastfeeding for the first 6 months of life and for up to 2 years or longer, as mutually desired by both the mother and the infant. The decision to breastfeed is very personal and influenced by many factors. Unfortunately, though, many of our patients are unable to meet their intentions due to various challenges, including education on how to establish and maintain milk supply, breastfeeding difficulties in the early postpartum period, limited access to support over time, as well as socioeconomic disparities. And oftentimes, this also includes just bad advice from healthcare providers. So, as pediatricians, we are well positioned to make a difference.
Yeah, absolutely. And that does bring us to another point. Where do we currently stand, if you know, on breastfeeding rates in the United States?
Yeah, so fortunately, we have pretty good, robust data on this. So, according to the most recent data, the 2022 Center for Disease Control Breastfeeding Report Card, 83% of infants receive some form of breast milk. Now, this includes even a single latch or express breast milk given by bottle or feeding tube after birth. So, this number doesn't tell us much. But we know that at 3 months, about 45% of infants are breastfeeding exclusively, which is great. And at 6 months, that number falls to 25%. These numbers have been rising in recent years, but there is still much room for improvement. And I think it's also really important to highlight that there certainly are disparities in breastfeeding rates. And so when looking at subgroups, these rates are lower in Hispanic patients, Black patients, and lower income groups.
Thanks so much for bringing that up. It really does sound like there's a lot of factors that go into whether families are successful in meeting their feeding goals. So let's now return back to the case with Katie and Alex. And if I remember correctly, he hasn't fed in about 6 hours. How do we assess and intervene at this time?
Well, first, we want to do a full feeding assessment. So, this includes evaluating the infant's alertness and hunger cues, assessing latch and positioning, and also checking for anatomical issues like a palate defect. It might also be a good idea to look at maternal factors, including the maternal past medical history that can affect milk supply, which we'll get into a little bit later, as well as a breast exam to assess for anatomic factors that may affect latch.
All right, that makes a lot of sense. So let's say the baby still isn't latching. What might be some of the steps you take next?
Well, we can try different positions to ensure that we've optimized our potential to get a proper latch and possibly hand express to help the baby get some colostrum. If the baby still isn't latching, we should focus on protecting the milk supply with pumping or hand expression and then considering alternative feeding methods like paced bottle feeds, even syringe or spoon feeding while working on latch. I find that syringe and spoon feeding is usually most useful for small volumes in the first 1 to 2 days of life. As we're approaching greater volumes, such as 1 ounce, then paced bottle feeding can make more sense.
Yeah, that makes a lot of sense. And there's a lot of tools that we use, and it's helpful to know some of this information when we're talking to families about it. And I know that we were talking about latch. Can you give some of our listeners some tips and tricks, potentially about positioning, how to achieve a good latch? Acknowledging this is a podcast and audio, but I'm sure there's some tips we can share over this sort of format.
Yeah, so I'll do my best to try to describe what an appropriate position looks like. So the most common hold is the cross cradle. I think this is one of the easiest for most patients to learn and one that usually lactation consultants focus on. In this position, the infant is positioned with their head to the breast and their tummy against the mother's abdomen, with the feet near the opposite breast. So, for example, if the baby is latching to the right breast, the mother should use her left hand to support the baby's head and neck, guiding them to the breast. And she should use her right hand under the breast in a sort of U shape to support and compress the breast to fit in the baby's mouth.
Okay, great. So what next things might we look at to know if the latch is then correct?
So first, I think about the positioning because appropriate positioning will optimize the chances of a good and deep latch. So the infant should be tummy to tummy with the mother, the nose at the nipple, and the neck, shoulders, and hips all aligned in a straight line. So for example, their neck shouldn't be twisted or turned. They should be in a straight line. When the baby latches on, their head should be tipped up. So imagine when you're drinking a glass of water, you're looking up, you're opening up that passageway, and the chin should be pressed against the breast with the nose pointing up. The infant should cover a large portion of the areola, and the tip of the nipple, if you imagine kind of where it's placed, it should be at the back of the mouth, ideally.
And why does this latch really matter this much?
So latch and positioning are important because poor latch will lead to inadequate milk removal and nipple trauma, which then further complicates the breastfeeding relationship. So, Chris, you have helped to troubleshoot the positioning, and great news, the baby latches on. He feeds for 5 minutes and then falls asleep. He's too sleepy to latch onto the other side. What would you want to do next?
Yeah. So I'm in the hot seat now. You want to make sure that there's no other pathology going on, though. So at this point, it does sound like there are no other signs of hypoglycemia or illness like we talked about earlier, but he's just likely sleepy and tired from being about a day old at this time. I might ask the lactation consultant if they're available to come back to the bedside to work with the mom and baby. But in the meantime, we will want to try to wake him up and feed on the underside potentially. And some of the things I recommend is to get the baby naked, change his diaper potentially, tickle his toes, use a cold wipe on his butt. There's many different strategies you can use, but I'd use something gentle to try to wake him up, and I wouldn't quit just yet. So Katya, I understand that starting on the right footing in the immediate postpartum period is really important. Why can't we just let the mother rest and recover in the delivery and feed the infant formula, for example?
So the hormonal milieu in the first few days postpartum provides the perfect setup to kickstart milk production. But without demand, this process can be disrupted. There are many hormones involved in gland tissue proliferation and initiation of milk production during pregnancy, which we won't get into. However, the basis of milk production occurs in about 3 stages. So lactogenesis 1 is the initial initiation of milk synthesis that begins during the second half of pregnancy. This starts at about 16 to 22 weeks, but high levels of progesterone from the placenta will inhibit further differentiation. So the early milk, colostrum, is produced adequately, but the progesterone levels prevent that copious milk production that we see after delivery. So lactogenesis 2 is that onset of the copious milk production, so the milk coming in, so to speak. And this occurs anywhere between 30 to 120 hours after delivery, but ideally it should occur by 72 hours. And this is triggered by the abrupt fall of progesterone from delivery of the placenta. And this allows a rise in prolactin, and prolactin is that hormone that stimulates milk production. So immediately postpartum, this is when prolactin levels are highest. And again, we refer to this process as milk coming in. Lactogenesis 3 is when milk production transitions from endocrine to primarily autocrine control. And that is just when continued milk removal from the breast leads to more milk production. And this is after lactation is established. And this is why people can feed their infants for years and years, and how wet nursing was done in the past. Because if you remove that milk, the body will make more milk. So let's talk a little bit about prolactin. Nipple stimulation leads to the rise of prolactin, and that in turn stimulates milk production. Then the complete milk removal tells the body to make more milk. So lack of removal leads to negative feedback mechanism that inhibits milk production. One thing to remember is that prolactin has a short half-life. So while we're working through lactogenesis 2, that milk coming in, we want nipple stimulation every 2 to 3 hours to maintain adequate prolactin levels. So if we don't create an adequate environment of breast stimulation and milk removal, we risk disrupting this whole process and increase the risk of low production and ongoing challenges that will affect their ability to meet their breastfeeding goals ultimately.
Thanks so much for going through all that pathophysiology. It's certainly some things that are new to me today, and it's really helpful to sort of put everything into context. So knowing all of this, what can we do now to support milk production if the infant is not latching and removing milk?
Yeah, so I think about 2 main priorities. Number 1, we want to make sure that the infant is fed. And number 2, that we are protecting supply by frequent milk removal. So in the first few weeks after delivery, while milk supply is being established, Milk removal should occur 8 to 12 times a day, about every 2 or 3 hours on average. And if the infant does not latch, ideally every time they feed, milk should be removed via hand expression or pumping. The early milk colostrum is very nutrient and antibody rich, and it is quite thick. So it might be more difficult to remove with a pump. And that's when hand expression may be helpful. This removed milk should be fed to the infant, and if there's insufficient volume, then formula can be used for supplementation. Ideally, again, every time that baby is fed, that they're feeding not at the breast, this should coincide with milk removal via pumping or hand expression.
That's really helpful to know. How do you recommend a family works together if there are more than one caregiver? And how do you determine if a child needs supplementation too?
That's a great question. So, trying to get the infant to the breast every 2 to 3 hours is great if possible. If this is not possible, the infant is not latching, milk should be expressed and given to the infant. Signs of insufficient intake may include excessive weight loss. And for this, there's no universal agreed upon number. And again, this will vary with how many days old the baby is. But approaching 10% weight loss is concerning. And other things to look for are signs of dehydration on exam and worse jaundice than normal. If there's not enough breast milk volume being produced, then formula supplementation can be a tool at this point to ensure adequate feeding while continuing to encourage building that breast milk supply. Also, family support is very important in promoting the breastfeeding relationship, and the patient's partner or support person is really vital. They can help in a lot of ways. They can help with feeding the express milk or giving formula feeds if needed, washing pump parts, and providing moral support because this is all hard work, and especially postpartum when mom is going through so many different experiences. This is a good moral support is super important.
Yeah, absolutely. I love thinking about how we can empower our families. And I think this is a great way to think about how to work as a team if that is possible for that family. I think another concern from families who are breastfeeding for the first time is whether a baby is getting enough. So, what sort of feeding volumes might you expect during the first few days of life to give people a little bit more of a sense of this?
Yeah, so typical feeding volumes are pretty tiny in the beginning and they increase each day. So, again, depending on the volume, formula supplementation may not necessarily be needed. So, in the first 24 hours, an approximate volume per feed is about 2 to 10 mLs. Then the next day, 5 to 15 mLs at 48 hours. And by 72 hours, a ballpark of about 15 to 30 mLs. By the end of the first week of life, most babies will be taking closer to like 60 mLs per feed. But again, this can be variable. So to help visualize the volume per feed, you can think of the first day as a small olive and next a bigger cherry tomato. And then by day 3, about the size of a lime. Frequent skin to skin should also be encouraged because this can help with bonding and also increasing milk supply.
Got it. No, that's really helpful. So let's say that Katie is able to hand express and spoon feed some of the colostrum to Alex. After working with the lactation consultant, she feels more comfortable bringing the baby to the breast and has been able to latch on a few more times. She has pumped 2 times and was able to get 15 mLs of milk each time when Alex was too sleepy to latch. They are now 48 hours postpartum, and things have been going well with the newborn hospital care, and he's otherwise ready for discharge home. So what feeding guidance do you give them for homegoing?
This is wonderful and amazing work, Chris. You have made a huge impact in this family's life already. So the family is now much more prepared to continue breastfeeding at home. So what I would recommend for homegoing is bringing the infant to the breast and continuing that frequent skin to skin and watching their feeding cues. So this may include lip smacking, licking and sucking their hands, or rooting. And that's when an infant turns their head when you touch their face. But we can't always rely on sleepy infants to show us feeding cues. So regardless, feeds should be offered every 2 to 3 hours during the day. And then at night, you shouldn't really be going more than 1 4-hour stretch. Since babies do not have significant reserves, this frequency of feeding is not only important for increasing their supply, but it's also really important for appropriate nutrition. So over the next few days, they may experience something called cluster feeding, where Alex may want to feed more frequently, which is a normal process, which will stimulate more milk production. Oftentimes, families are worried that this is a sign that their baby isn't getting enough, but this is just a natural process that will tell the body to make more milk. But if it's been more than 3 to 4 hours and Alex doesn't latch on the breast, his mother should pump or hand express to remove the milk. And I would also ensure that they have good follow-up set up with their pediatrician and lactation consultant to check in during the coming days.
I really love that we're thinking about follow up with the family, and it sounds like they're in a good spot for discharge. So, did Katie and Alex have any risk factors for difficulties with breastfeeding? And I do know that we had talked about revisiting this as well.
Yeah, so this is a really important question. There are multiple risk factors for delays in lactogenesis too, that milk coming in, as well as risks for lower milk supply. So these may include delivery by C-section, pre-pregnancy maternal obesity, and then prematurity or being the first child. And all of these apply for our diet. So additional risk factors to think about in other patients include gestational diabetes, gestational hypertension, or other hypertensive disorders of pregnancy, such as preeclampsia, advanced maternal age, premature birth, postpartum hemorrhage, just to name a few. It is important for us to recognize that these patients are higher risk so that we can provide them prompt support and intervention.
Those are some really great pearls. Let's now imagine that Alex and his family did not get this education or interventions in the hospital. And let's say instead that while in the hospital, Alex was unable to latch again and he was bottle fed formula. His mother was unable to start pumping after discharge until 48 hours and was only getting about 5 mLs at a time during each pumping session. They now present to your clinic at 4 days of life for their first newborn visit. Alex is down 10% from his birth weight. He has been intermittently latching, but his mother reports that her nipples are very sore and painful. She has pumped 2 times yesterday with minimal milk excretion. Prior today, she hasn't noticed much change in her breasts. However, this morning, she has noticed her breasts feel more full and firm. What would be your recommendations at this time? And is it possible to return to exclusive breastfeeding now?
So, unfortunately, this is a pretty common scenario when the infant wasn't able to latch on while in the hospital, and parents aren't really sure how to feed the baby and how to protect their milk supply after discharge. The nipple pain and soreness is likely due to nipple trauma from inappropriate positioning and latch, which also leads to ineffective milk removal by the infant. In this case, I would return to those two priorities we've previously discussed. Again, number one, feed the baby, and number two, protect the milk supply. This infant is 10% below birth weight and really needs to be fed. He appears mildly dehydrated, has minimal tear production with crying, and has jaundice to the nipple line. Since Katie's breasts are more full and firm, that may be a sign of the milk coming in, and so she likely has some milk, and you can assist her in getting Alex to latch in the office or assist her in hand expressing or pumping so that he could get that expressed milk. He also may need to be fed some supplemental formula until the milk supply is appropriate and he's able to latch appropriately to remove that milk. He should be offered expressed breast milk or formula every 2 to 3 hours, and Katie should pump to remove milk at least 8 times per day. They ideally should see a lactation specialist to help work on the latch and positioning as soon as possible, as we would like to get the baby back to feeding at the breast. And he should also have close follow-up with a weight check in the next 24 hours. The good news is that if we intervene now, they still have a good chance in establishing a good supply and continue their breastfeeding relationship. If we do not intervene and provide additional support, they may be at high risk of stopping breastfeeding prematurely.
So, Katya, what are some resources parents should be aware of for additional support at this time?
So support really is key here. Most pediatricians are able to refer to a lactation consultant in the community, and these visits should be covered per the Affordable Care Act by insurance. Breastfeeding medicine physicians are doctors that may be a great resource. They're physicians who have unique training in breastfeeding and lactation medicine and are often helpful in some more complex breastfeeding challenges. And then for patients that qualify for WIC, the Women, Infants, and Children's program, they can have access to peer counselors and sometimes lactation consultants through their local WIC clinic. WIC can also help provide formula for families in need of that support and can provide food benefits for the patients or family to offset costs, especially when families are breastfeeding. Additionally, the Affordable Care Act requires insurance companies to pay for breast pumps, so most patients should have access to a pump. Also know that the lactating parent is legally protected to have pumping breaks at work, so you can remind families of this and support them with a doctor's note if that may also be helpful.
So where can residents and trainees find resources and more education about breastfeeding and lactation? Since this is hopefully a really good place to start, but there's a lot more to learn, I'm sure.
Yeah, and thankfully there are many great resources. So the AAP has a breastfeeding curriculum for trainees. It's available on their website and it's self-paced and covers some of the most important topics related to breastfeeding and lactation. Now, for someone who wants more in-depth training, the Institute for the Advancement of Breastfeeding and Lactation Education, IABLE, has physician-focused education, modules, and courses, which can be a wonderful learning resource. And I also want to give a shout out to the Academy of Breastfeeding Medicine. They have developed many protocols which provide evidence-based guidance regarding breastfeeding and lactation-related topics and are just an amazing reference, especially in more challenging situations. And then Stanford has a wonderful site for breastfeeding education that is geared towards patients as well as physicians, and they have many great topics that are related to newborn care as well.
Those all sound like really wonderful resources. Thank you so much, Katya, for sharing your experience and really helping to lead this discussion about breastfeeding. And it does sound like we helped Alex, Katie, and their family get on the right track to help meet their feeding goals, which is really exciting.
Yeah, Chris, thanks so much for having me. It's been my pleasure and it's been so fun going through this case. I really hope that the episode helps our listeners feel more comfortable supporting breastfeeding families. And hopefully, this also inspires people to get a little bit more education and look at some of these resources that we discussed to even further their education.
So, in terms of takeaways from this episode, I hope you will feel more confident in managing the common breastfeeding concerns that often arise in the newborn period. Know that feeding difficulties in the first 24 to 48 hours of life are common, and that the very first step is to assess whether the infant appears well before troubleshooting feeding concerns. Take time to understand the family's feeding goals. This will allow you to provide tailored, supportive guidance that respects their preferences. Know that a thorough feeding assessment includes evaluating both the infant and the breastfeeding parent. Observe for hunger cues, quality of latch, positioning, and any maternal or anatomic factors that might impact feeding. I also hope that you now have a better understanding of the significant health benefits of breastfeeding, including protection against infections, chronic diseases, and long-term mortality, both for the infant and the lactating parent. This knowledge helps us answer questions families may have and advocate for the importance of breastfeeding when appropriate. Early education and timely support make a big difference. Encourage early and frequent milk removal, ideally every 2 to 3 hours, to support the hormonal changes necessary for establishing supply. Be aware of risk factors for delayed lactogenesis, like cesarean birth, prematurity, or maternal obesity, and offer early intervention when needed. Know that supplementation decisions should be individualized, guided by signs of dehydration or inadequate intake, but can still support breastfeeding goals if paired with ongoing milk expression and lactation support. And finally, don't underestimate the power of teamwork, involving lactation consultants early and connecting families with community resources to help equip them with the tools they need for a successful feeding journey. I want to share a big thank you to Katya for creating the content for this episode, and to our expert reviewers, Dr. Brittany Allen, pediatric hospitalist, Dr. Annie Yarborough, general pediatrician, and Dr. Jody Ehrman, pediatric hospitalist, for fact-checking this episode. Thanks again for listening, and we look forward to seeing you next time.